Hello everyone, and a very warm welcome to our BMJ Case Reports writing workshop. My name's Elena Kalsef and I'm the Senior Marketing Manager for BMJ in the Asia Pacific region, and I'm based in Sydney, Australia. I am really delighted to introduce you to the Editor-in-Chief of BMJ Case Reports, Seema Biswas, who is presenting our workshop today. Seema has been Editor-in-Chief of BMJ Case Reports for many years, and she's also a General Surgeon. Over the next hour, Seema is going to share all of her knowledge and expertise and lots of practical tips with you to help you successfully write, present, and publish your own case in BMJ Case Reports. We'll have about 15 minutes for question time at the end of the workshop. So if you do have any questions as we go along, please feel free to submit them using the Q&A icon, which you can see at the bottom of your screen. And we'll then come back and address those questions at the end of the workshop. All attendees will receive a copy of the webinar slides, and we're also recording the webinar today. So you'll receive a link to this recording too. Please keep an eye on your inbox over the next couple of days for those. Before I hand over to Seema, I'd just like to give a very special welcome to the vast majority of our guests today who are based in Japan. Japan is actually one of our top countries for both submissions and accepted papers to BMJ Case Reports. So it's great to have you all here. I'd also like to mention that we do have some caption functionality. So if you are interested in turning on Japanese captions for the workshop, you can do so again at the bottom of your screen by clicking on the Show Captions button. Okay, I think that's it from me. So without further ado, I'll hand over to Seema. Thanks, Seema.
Thank you. Thank you very much, everybody, for joining us at the webinar. I'm very excited to hold this first webinar that I will be conducting myself with our colleagues in Japan. So welcome to all of you, and thank you very much for taking the time to join us. If you bear with me for a moment, I'm just going to share my screen. And you should now be able to see a full screen version of a PowerPoint presentation. If for some reason you can't see that, then please do let me know. So I'll begin with a little word about myself. BMJ Case Reports has been around since 2009, and I became the editor-in-chief in 2010. Now, one of the first things I did when I became editor-in-chief was, with a background of teaching and examining medical students and junior surgeons, what I wanted to do was open up the journal. Instead of being a case report of something rare and weird and wonderful, or a new disease or a new treatment, what I wanted to do is have a selection of challenging cases, well-managed cases, cases that present a dilemma, and cases which we would tend to discuss ourselves amongst colleagues in hospitals, and perhaps present in a hospital large meeting or a lunchtime grand round, and have those cases discussed in particularly that manner, where we're scrutinizing our management and looking to see how better we might have managed a case. That's the kind of case that we're looking for. So we do publish cases about rare diseases. We do publish cases about new treatments from time to time. But what we focus on is being a learning resource. It should be possible that whatever background your clinical practice is, if you come across a challenging case, you could go to BMJ Case Reports, look up the search function in Case Reports, and find a case that's fairly similar that was managed, and that their management decisions might be of assistance to you. So we're looking for cases that are great textbook teaching and learning cases. We are primarily a learning resource rather than a case report journal that's looking to publish rare and weird and wonderful patient experiences. So that's a little bit about the journal. And what I'm going to talk to you about today is the guidance that we've produced. Hopefully you have access to the BMJ Case Reports website at the same time that I'm talking. I'm also going to introduce you to our templates for writing. We'll look at a few examples that we won't go through cases, but we'll look at a few examples of how to write. I want to introduce you to the author statements form, and then I'm going to go through the review process, because I think the more authors understand about journal processes, what the journal's looking for, and how reviewers treat a manuscript, the easier it is for you to write and the more successful you are. So again, what are we looking for? We're looking for something new to learn. I don't mean a new disease, and I don't mean a new treatment. What I mean is information about difficult or challenging cases or interesting cases or a new disease where all the audience, whether they're from your clinical background, whether they're medical students, whether they're junior doctors about to sit an exam, they can learn from that. So as an example, yesterday, I was looking at a manuscript where a patient with a history of malignant melanoma on his back presented years later with small bowel obstruction. And he had small bowel obstruction because he had an ileocecal melanoma metastasis that had caused an interception. Now, is there anything new to learn there? Not really. It's a reminder of an important lesson, and that is that patients who present years later with a slightly unusual disease but have a history of melanoma might have a metastasis from that melanoma. But how can we make that something where there's new to learn? Well, what I asked the authors to do was to include a table of common sites where patients who've had melanoma previously might present with a metastasis. Do you see? That's how you introduce something new to learn. The second table I asked the authors to include was a cause in adults, not children, because in children we expect ileocolic interception. But in adults, causes of ileocolic interception, I mean, they're usually extremely rare. They're usually polyps. They're usually primary carcinomas of the cecum. But it's very, very rare to have a metastatic lesion in the cecum or the colon or the ileum, as you know. So this is what I mean when I say they're typical cases, patients that you might have in your department, but you present something new to learn. It would be as if I'm there with you and you've just finished your work for the morning and you say, Seema, come over here, come with me. Come and meet this patient. You won't see this very often. I want you to examine their abdomen and tell me what you think. Seema, come over here. Have a look at the CT scan. This is a very unusual finding. Tell me what you think it could be. So we're talking to each other all the time. And one of the joys of doing this webinar is that I'm here. I'm not a robot. I'm not a bot. I'm not a virtual image. I'm a real person. And when you're writing cases which, you know, I'm going to read and I'm going to learn from, and I'm going to ask you questions about, could it have been this? And when was it that the patient actually developed abdominal distension? And we ask each other questions as if we were working together. So there you go. So I've talked about what I mean by something new to learn. And I'm not talking about a new disease. I'm talking about existing conditions, existing clinical cases where you're finding the learning value of that case and publishing that. And the second thing we're looking for is that it's completely based on the patient. In a case report, the whole case report is written around the patient's story, which is the case presentation. That needs to be comprehensive. The details need to be correct. It needs to be presented with a timeline, which I'm going to explain in a minute. A timeline helps us understand what happened and when and why something was done. And unlike any other case report journal that I've come across, there is a special section in the template where the patient can write about their own experience. And there we're not looking for a statement of thanks to the doctors or gratitude that the patient's alive or recovered. We're looking for the patient's experience of what they thought their symptoms meant, when it was they came to you for help, how they dealt with the treatment, how they dealt with side effects, how they're living now with a disability perhaps, or with a slow recovery, or returning to work, and whether they can work in the same way that they did before. That patient experience hugely enriches a manuscript. And so what we get when we add something new to learn from a routine clinical case, and we keep the manuscript entirely centered on the patient, is we have what I call online bedside learning. It is as if you are taking a medical student or a junior colleague or a colleague who's fairly senior but from a different specialty to the bedside of a patient, and you're pointing out the clinical signs. You're giving someone the opportunity to correlate those clinical signs with pathology, and you're allowing them to take part in the treatment and go with you on your journey as you decide what the best options for treatment are, how to mitigate side effects, how to mitigate a lack of response to treatment, and change your treatment course. And all of that is bedside learning. It's classic bedside learning. It's the best way to learn medicine, but we're doing it online. And why is it so important? Well, it won't come as any surprise to you that during the COVID pandemic, our case reports were downloaded the most to use for medical students to learn, because they couldn't come to medical school and they couldn't come to the hospital to see patients. So in this era where I'm not sure if you suffer from this in Japan, but certainly what we're finding in Europe is that students have less and less face time with patients. They can't get their hands on them to examine them. There are more students than there are patients. There are fewer clinical facilities. Nowadays, online bedside learning is an enormously valuable tool for medical education. And it also helps us link across the world in terms of what you're seeing in Japan and what we might expect to see here in Europe. There's a brilliant way of sharing medical information. What are we looking for in every manuscript? Something new to learn about a typical case that is entirely patient-centered with the patient's point of view. And what does that make? It makes a manuscript, a published paper, that is perfect for online bedside learning. So, how do you write? Go to your department as soon as we've finished this webinar and look at any one of your patients. Any one of those patients will have something that's interesting about their treatment, something that's interesting about their condition, where you could be saying to me, Seema, come over here, come and look at this patient's ECG and take a history from the patient. I think you'll find it very difficult to correlate their signs and symptoms with what you find on the ECG. What do you think could be the reason why we have this, I don't know, prolonged QR interval? So you take me to the patient, involve yourself with the patient from the very, very beginning. Say to the patient, because you have this abnormality and because it's not something that doctors often pick up easily, we want to write about your case and we want to publish it in this journal. Take your phone and show them the BMJ Case Reports website and tell them that this is how we want to publish it. This is how it would appear. Go ahead and show the patient an already published case so that they know how their information, it's their personal information, how it will be used. Then go back to the website and we'll show you, if we have time at the end, how to download our templates. It's in the instructions for authors section, and perhaps Elena and Kim can share that link with you in the chat. So when you go to the BMJ Case Reports website, download our templates under the Authors for Instructions page. And then literally, when you're looking at that template, as you read the instructions in the template, you should be able to hear my voice reading those to you to say, please write a straightforward clinical title, no jokes, No puns, no exclamation marks, just include the diagnosis and your main finding. Please write a 150-word summary. Why should it be 150 words? Because a summary for a case report is the equivalent of an abstract for a published paper, and PubMed insists on 150 words. So use those 150 words. That's the window into the whole case report. So it should be a summary of the entire case report. Use only formal medical English. So don't use can't, don't, won't, shouldn't. Use cannot, did not, should not, would not. Don't use exam, use examination. Don't use blood draw. Use serum investigations or laboratory investigations. Don't use medical colloquialisms like the patient's doing well. Write that the patient has fully recovered. And now the most important part, which I'm going to show you a few slides in a moment, is examples. Use pictures. Pictures paint 1,000 words. Pictures are so important. Pictures are what illustrates the case. It's what brings that patient into my home online, even though I'm continents away. That is the online bedside learning. There's no substitute for images, pictures, tables, diagrams. They are so useful. You can use flow charts of how it was that you made your decisions and how one decision led to another, how one complication led to another. Now, anonymize all patient details. Now, what do I mean by that? Instead of saying a 53-year-old man, write a man in his 50s. Instead of writing a 55-year-old man who worked in HSBC Bank, write a man in his 50s who worked in an office. Because it's only important for us to know that he did clerical work, that he had a sedentary job, or that he wasn't doing manual labor. So remember why it is that you're mentioning a personal detail. And if it's important clinically, then put it under a broad category that doesn't help me to identify who that patient is. Why are we so strict about this? Because we live in this online age of social media where we invite people into our homes the moment we're online. And you should be able to choose whom you invite, but you can't. And a patient has consented to their information being used for medical learning. Yet all sorts of people download case reports. All sorts of people have access just through simply Googling an image. They might end up Googling an image from your patient. So please, please anonymize all patient details. Don't have pictures of faces. And unless it's really necessary, try not to have pictures of genitalia or any images that present a patient at their most vulnerable. And we can discuss that at the end of the presentation if you have questions about that. What is informed consent if it's a case report? Informed consent is from someone who has read the manuscript and agrees with the words and the pictures that are on the manuscript and understands, remember how I told you to show them the journal? They understand how that information will be presented. That's informed consent. Informed consent isn't just a signature that a patient agrees that, yes, I'm happy for you to use whatever clinical information you need from me in order to teach somebody else. Because patients will always say yes, because it's they feel that they're really contributing to medical education, to improving someone else's health if they share their information. But that's not quite the same as informed consent for publication. They must be aware of the fact that our images may be downloaded by other people who are not doctors. They must be aware that some of their medical information will be known to people who already know that they were ill, perhaps to their neighbors, perhaps to their family. So informed consent is important. Now I'm going to talk about what the reviewers are looking for in a moment. But when you receive review comments, Remember that this is a collaborative process and we're friends here. There would be no journal without our authors, and our authors are valued. Your contributions are valued. If a manuscript is rejected, the manuscript is rejected. The authors are not rejected. The authors are always valued, and the work of the authors is always valued. So when you receive comments that say, please add this, please clarify this, please include this information, please upload the pictures of the histopathology, we're not doubting what's written, we're just asking for more information. These are the same questions we would ask each other if we met face to face and we were talking about a clinical case. So take each point that you've been asked, write it down as a question, and then write your response. When I'm going through a revision, the most important thing about a revision isn't exactly what you've written in your responses, because sometimes you agree, sometimes you disagree with the need for a change, and that's fine. You can agree or you can disagree. That's absolutely fine. But what's very difficult for editors and also for the reviewers when they're looking at a revision is when you just say it was done. Well, we don't know what was done, and we don't know, we can't see exactly where it was done. So although we can look at the manuscript and we can see the tracked changes, that's not the same as a detailed point-by-point response to each of the reviewer's comments. So please, please always upload a detailed point-by-point response to each of the reviewer's comments. You might not agree with them, so you might say, thank you for this comment, but we respectfully disagree. We don't think that that is relevant in this case because, and such, and you outline your reasons. And sometimes those reasons are so good, I'll say to you, can you please incorporate that into the text? Because this is important learning, that we didn't need to consider these other diagnoses because, as you've pointed out, the patient clearly had these symptoms, and that's why you chose this course of treatment. So address all reviewer comments as if they're just a discussion amongst colleagues. This is not an adversarial process. Publication is a collaborative process. So I always choose this slide as my first picture because people always say to me, well, if you're not publishing rare things or weird things or new diseases, surely you don't mean that we can just publish any patient and any sign on our ward. And my answer is, yes, that's exactly what I mean. Please do send us the story of any patient that's there in your department right now. Now, what is the first thing you learn when you go to medical school? The JVP, the jugular venous pulse. Why on earth would I publish a case report about the JVP? Because unless you're very different from me, when you were taught the JVP, you were nodding, saying, yes, yes, I know what you mean. Yes, yes, I can see it. And you weren't really sure what you could see. Now that we live, I learned medicine as a medical student and the JVP more than 30 years ago now. But now, if I could see a video and I could see it close up, and let me put my glasses on, I can see it even better now. And then I had my little book in my hand and I was looking at the trace and the A, C and the V wave and the X and the Y descents and trying to understand what the dichrotic notch was, and then trying to coordinate what I see flickering in the venous pulse with feeling an arterial pulse. And look at this. Here you are, online bedside learning. You can see someone's neck. She has constrictive pericarditis, so the jugular vein is slightly more distended and easier to see. And now, in real time, I can play this video when the patient's inspiring, so breathing in, and I can see exactly how the wave in her neck changes. I can see exactly here what's flickering, and I can coordinate it with a moving trace of the JVP. And then I can click on the next video, which was in this manuscript. And if you want to look it up, here's the BCR number. And here the patient is breathing out, expiring. And then I can learn how that JVP changes with inspiration and expiration. And then it's an opportunity for you in that case report to explain how intrathoracic pressure changes when you're breathing in, and how this extra negative pressure will bring up the blood and increase venous return, and why I should see my veins filling more. Such a wonderful way of illustrating a fairly basic medical principle. So what are we looking for? We're looking for online bedside learning. If you can, send me classical information in a new way to learn and add that to a completely patient-centered way of learning, looking at the patient's neck, that equals a valuable, publishable online bedside learning. This is how to get published with BMJ Case Reports. Here's someone with a distended umbilicus, which is full of venous blood. And this is a caput medusa, and it's a reminder of the head of Medusa, and then all the veins that come out of the head, which are little snakes. And a quick diagram drawn by the authors just to remind us of what it is that causes this obstruction within the liver of venous blood, and where I might expect to see these portosystemic anastomoses. Another example, and you can see this hand-drawn, beautifully hand-drawn diagram of a lump in the groin. And during COVID, all sorts of doctors were having to see patients with surgical conditions. They weren't necessarily people who had a lot of experience of surgery. A quick reminder of the anatomy of the groin to understand what it could be that causes a lump in the groin was perfect. Now, do you remember I asked you to present diagrammatically the clinical course of the patient? So here you are. Here's the date when the patient presented, and then subsequent dates. We don't want to see dates now, because since this slide, we've anonymized dates. So you would start with admission 1 month later, 2 months later, 3 months later. It's why I always keep this slide in, because it helps me to remind authors that we want to anonymize information. And here you write the clinical event. You might even include some of the imaging, but then you correlate that with the treatment and when the treatment happened. And for someone who doesn't know this patient, who's looking at this from the other side of the world, it helps me understand what it is you've written in the text. And I say, aha, when the patient came in, they didn't have this, but then they went on to have this other symptom, and it was treated with this, and that didn't work, so they added in this other treatment. Oh, I see, they only had such and such for a very short time. Do you see? And you can also include the follow-up information here as well. But this clinical course, this diagrammatic timeline of the clinical course, greatly enhances the manuscript and makes it easier to learn. This is another example. So we don't have a template for how you present this. You can do it in any way you want to. So this is another example of a timeline. Now look here, do you see that this says time 0, 10 minutes later? This is an example of how you might anonymize times. So we don't want to see any times or dates in the text or in the pictures that go with your manuscript. Here's another one. So before the patient came to hospital, so -1 week, the time of admission, a week later, 2 weeks later. Do you see that? And here, this is wonderful. I can see, right, so the patient was intubated and ventilated as soon as they came in. They were woken up just before the end of 2 weeks. They had their MRI brain after they were woken up, obviously because you can see that there might be something neurologically wrong with the patient once they've woken up. You can see that they had their tracheostomy at about the 3-week stage. Now that's unusual, isn't it? We would have done it probably within the first week. But you can see what the patient had done. And it also helps you when you're reading the text, understand, aha, so that's why they did it then, and that's why they did this later. And I see it wasn't clear initially what this might be due to. And you've also got the rehabilitation stage here. So it's not just the acute illness that you have to cover. You can cover the whole patient journey. in exactly the same way, you can illustrate your results. So rather than just presenting a table of results or just explaining the numbers in the text, why not have a graph? It's such a great way of seeing how the patient was when they were most unwell and how the patient is now. Another graph, I love this graph because this was one of my exam questions in my first surgery exam about 30 years ago. And I had to draw the trace of a Swan-Ganz catheter as the catheter feeds through the chambers of the heart. Now, this is such a wonderful learning experience for the reader who sees that this Swan-Ganz trace that you would normally see in a textbook really belongs to a real patient and what it was that you encountered in a real patient. This graph puts together different information. It's talking about a patient with a hormonal abnormality and how it changes with age, how the hormone levels change, but also how the child grew. So presenting information graphically and combining different pieces of information so that we get the overall picture of how the patient progresses is so important. I'm not sure whether you can see this, but you can see how the patient's trunk changes before and after treatment. And you can see that here, there's a little bit of truncal obesity developing as a result of steroid therapy. Mechanisms. No, not new mechanisms, not unproven mechanisms, but mechanisms that are established that we should all know about. Why not remind us of why it is that someone's lactate is high in sepsis by showing us the reasons why oxidative metabolism can't take place? Why not show us a little bit about norepinephrine? Put that in because that's where your online learning comes in. Is there something new to learn from this manuscript? Perhaps there isn't completely new information, but classical information is presented in a new and memorable way. And it's illustrated, it's shown as a graph, it's shown as a table, it's shown as a diagram. Another diagram, this is about refeeding syndrome. Now, we all know that when someone is badly undernourished, you can't feed them normal amounts of food in the same way. But why? And this is a reminder, I don't have to look up another book to tell me. I can read one case report and all the information is inside the text of that case report. And these tables, these flowcharts are all drawn by the authors. They're original diagrams of the authors. This too, an original diagram of the author. These are manuscripts where it would be almost impossible to reject a manuscript like this. And this is what makes the journal so famous and #1 for online bedside learning. So here you are looking at an operative picture and everything is labeled. Everything is labeled. We have videos of operations where everything is labeled. The operative approach is illustrated. All the questions you would have if you were a medical student looking at that screen in the operating theatre, wondering what's going on, wondering what is what, losing your orientation as the camera angle changes. All of that is labeled and described by the authors in our images and videos of anatomy. I like this picture because it shows you what you should never be able to see. Someone has had a fasciotomy. Now, in a fasciotomy, as you know, you really need to get under the tissues in order to free up those tissue planes. So although the incision's here, it's this extent that has been freed up and this extent that has been freed up. And how better to illustrate it than superimposing using basic computer software, something that comes free with a Microsoft package, over a clinical image. This is not Microsoft software, this is just hand-drawn, but it shows me exactly where to make my osteotomy. There you go. So the diagrams, as long as they have really good learning value and they're well drawn, If you don't want to use basic software, we'll accept hand-drawn diagrams. Learning value again. Now, I'm looking at this X-ray and I can see that arrow, but I can't see exactly what it is that the authors want to draw my attention to. So what the authors do is, beside that clinical image, they hand draw exactly what it was I should be looking at. That is online bedside learning. That is added learning value. That is what gets a manuscript published. They've done exactly the same thing here, using very basic drawing software. They've taken the CT images, where we're all nodding, saying, yes, 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 I see that. And what they've done here is they've enhanced the parts that I really should be looking at. They've put the arrows there again so that I know exactly where to look. Valuable bedside learning. This is what makes a case publishable. A digital subtraction angiogram. Well, I've subtracted all the anatomy that could help me identify what's what. So what have they done? Beside the digital subtraction angiogram, they've added in the anatomy so that I know where I am. I know what I'm looking at. This is what makes the journal excellent online bedside learning. So to summarize, what are we looking for? We're looking for something new to learn, but it doesn't have to be a new disease and it doesn't have to be a new treatment. All we're looking for is that you keep it patient focused. You discuss your clinical challenges openly, because there, but for the grace of God go I. It could be me who's struggling with a patient. And if there's a delay in diagnosis, there are good reasons why that delay might occur. And it would be the same no matter who was looking after the patient. This bedside, radiological, interventional radiology, procedural learning with the anatomy, with the physiology that I showed you, working out differential diagnoses, having these flowcharts, having those clinical timelines, being honest and open about discussing difficult decisions where guidelines don't cover what you have to do, where protocols are limited in how they can help you. And at the same time, keeping the patient the center of learning. And we want the patient to tell us, what was it like for you to have this disease? What was it like when you were in hospital? Perhaps a young mother in hospital who's got children at home, who's looking after the children. How did they respond to treatment? How did they deal with the effects of treatment, side effects, perhaps the loss of a limb? Living with disability. So remember, novel learning, something new to learn, information presented in new, interesting, and memorable ways with illustrations, and the patient story, keeping the patient presentation detailed and central to your manuscript. Remember what I've said. In the patient perspective, we don't want a sentence of thank yous. We really want to know, in the patient's own words, exactly what they went through and what it was like for them. Now, it's tempting when the patient's writing this to give away a lot of personal information, but please, after the patient has told you what they want to say, or the patient has handed you in writing what they say, go through it and cross out the identifying information. We don't want to identify the patient. We don't want to identify their family. Those details are counterproductive, whereas knowing what the patient experienced is valuable. You're not losing anything from the perspective by removing personal information. One last word about informed consent. Most of you will already have seen on our website that we have the consent form in Japanese. If you come across a patient who speaks a different language, then please let us know, and we will get consent forms translated and we'll get them over to you. But we do require informed consent. We do require that it is signed. For patients who are not, I suspect this won't be a problem you encounter very often, but we'll accept a thumbprint from a patient. If we know that the patient has seen the case report has been read to them if they can't read it themselves, they're fully involved with the process, they're totally on board with knowing that, yes, this is me and my published images will be online and A stranger may be reading them. That stranger may not be a doctor or a nurse or a physiotherapist. It is so important that we have informed consent. So please involve patients from the outset. Don't start writing after the patient has gone home. If they live somewhere remote and you can't contact them, keep the patient central to the whole writing process. Now, I'd like to take any questions that you have. I promised I'd finish in 40 minutes, and I'm on time. So would you please send me your question? And while you're doing that, I'm just going to go to the last slide, which is about global health, just to give you a taster, to tell you that we publish global health case reports. They're the same as our clinical case reports, but they look at the causes of disease. So rather than discussing pneumonia, you would also discuss why the patient has pneumonia, because they live rough on the streets, because their work involves being subject to adverse weather, because they're undernourished, because they can't afford to eat healthily. So we have global health case reports, and on a different occasion, I'll discuss them in much more detail. But let's go back to your questions.
Thank you so much, Seema. That was a really insightful workshop, and I'm sure everyone found it very useful. All those examples were just fantastic to see. So we do have some questions that have come in. So just a reminder to everyone, if you could submit your questions using the Q&A icon at the bottom of your screen. Unfortunately, because we have quite a large number of attendees today, we're not able to take any questions verbally. So if you have raised your hand, if you wouldn't mind, please just typing in your questions. That would be very helpful. Thank you. All right, so the first question that we have, Seema, is are there any good textbooks or manuals for formal medical English? And is this for UK English that we're talking about?
You can use US or UK English. And provided we can understand exactly what it is you mean to say, we can help you with our BMJ language editing service to get it to the standard that it's publishable. Now, I'm sure Elena will share the link with you for the English language service. So we will help you with that. So all we need is for you to write it in a manner where we understand exactly what you intend to say. And we can help you with the English. It doesn't have to be British English, it can be British or American English. We do not want language to be a barrier to publication. We especially want manuscripts from every part of the world. In the modern world, you cannot learn medicine without learning global medicine. So let us help you with that. Don't be afraid of the English.
Thank you, Seema. Okay, our next question. Is there any format for informed consent by medical staff?
Yes, I think there is. I think it should be very similar to how you obtain clinical consent. So you download our consent form, you talk to the patient at the time they're with you. Face-to-face is always better. You'd say to them, look, we want to write a case report about you. We're going to focus on this and this in particular. It might mean that we need pictures. Remember what I said, avoid a picture of the face. So let's say that someone has a rash on their face and you really want to show that it's on their face. Take a picture of the rash, a close-up. Remember, you can't see anything of a rash unless it's a really close-up image anyway. And what you could do is you could just transpose that on a diagrammatic face. So you're not seeing the picture's face. And show the patient that so that they know that it wasn't their face that was on the manuscript. Do you see that? So show the patient exactly what you've written, even if the manuscript is in its draft stage. And then read the consent form to them or let them read it. They can read it in Japanese. And then leave it with them for a little while and then come back and see whether they've signed it and ask them questions. They can withdraw their consent at any time. It's very rare that that happens, but we put the patient first. It's a patient-centered journal. If for some reason they have any concerns, then we won't publish. But For informed consent, it begins and ends with a conversation and with them looking at the draft of what you've written.
Thank you, Seema. Okay, next, can you please share which software you recommend for the images?
I use the drawing software in Microsoft Office. It comes free with my Microsoft Office package. And I'm terrible at drawing, but I find it so much easier when I'm using computer software to do it. My hands shake and I have a tremor, and I'm not good at drawing. My mother's an artist, but unfortunately I'm not. Whereas I use this Microsoft software, and anyone would think I was Pablo Picasso. It's wonderful, and it's free. It's free. We don't want you to have to co-opt you know, some graphic designer for things. But you can see, could you see during the presentation how much value these illustrations added? You could see that, couldn't you?
Sure could, yes. Nothing beats being able to see it. Okay, next question we have. So a comment first. BMJ Case Reports requires a specific consent form, which can be burdensome for patients and physicians. Would it be acceptable to use a consent form from another or a different style a different style form?
If you have access to our BMJ consent form at the same time that you're with the patient, always use our form. Why? Because many, many years ago, more than 10 years ago now, I went down to the legal department at the British Medical Journal, you know, in BMA House in London. And I said, look, I have all these images of people's faces, that I have illustrations of their lives and how diseases affected their family. If I'm going to publish this, and if a newspaper is then going to take up the medical story, think of COVID, think of how people were publishing during COVID, then I need protection for the patient. And I also, because it's difficult now to get images and x-rays and CT findings, PET CT, ECGs, where I can write exam questions on, where I can use them for other learning resources, I need permission to use a BMJ case report in the BMJ companies for other learning resources. Can you design a consent form that covers all of that? It protects the patient and it protects the BMJ, and most of all, it protects the authors. And that's the consent form that you're downloading. So it's so important that you use our consent form because it's specifically designed for all the challenges a patient, a doctor, and the publisher might face. Now, I know that you have your own consent forms, but look at your consent form against our consent form. And if the same things are not covered, then there isn't any point using a local consent. Use our consent form. If you have a specific problem with consent, then write to us, but write to us before you submit so that we can help you. But always, always, if you can, please, please use our consent form. We're much stricter about it now than we used to be, because we have had examples of false information and non-informed consent, and we just cannot put a patient in that situation.
Thank you, Seema. Continuing with the consent form theme, a couple of other questions. So firstly, do we need to include the consent form from the patient when submitting? And what if the patient has passed away but had given consent beforehand?
Lovely. So yes, please upload the consent form when you're submitting. And we also have another form. It's called the author statement form. If any of you have access to the website at the moment, if you could go to the BMJ Case Reports webpage, Elena, you might want to do this and share your screen perhaps. Go to the instructions for authors page, and you'll see a blue bar across the middle of the page where you can click on different headings. You'll see the consent bar, and you'll also see something that says an author statement form. The author statement form gives me more information about how you took consent and also who was involved and who it was that took consent. So lovely, lovely. So you'll see that it says authors. Do you see that? BMJ Case Reports at bmj.com, pages and authors. This is the one page that you all need to know about. Now, on that author statement form, we need to know that it wasn't a medical student or a junior member of staff that took consent. It needs to be the most senior person who is responsible for the patient's clinical care and the most senior person who is supervising the writing of the manuscript. Now, if the patient has died, but we know that the most senior person had the discussion with the patient before they died, they may even have signed a consent form before they died. The most senior person is speaking to the patient's next of kin, and the next of kin has signed what we call a deceased patient consent form. So you'll see we have a consent form, again, designed by us specifically for when a patient has died. You'll see it in the consent section. Fill out the deceased patient consent form. If I know that now that that patient has gone, their family, the family that is closest to them, have no issue with publication of that case report, then we're fine. This is why I started the whole conversation about consent by saying it's all about what you say to the patient, that we need evidence that you had an honest conversation and that when that conversation took part, they had seen a draft of the manuscript. And this is why it's so important that you start off the writing process when the patient's with you and that you stay in touch. If at least not in touch with the patient because the patient has died, stay in touch with their family, their next of kin. Now, have I answered all the questions that you asked in that question? Did I miss out part of that question?
No, I think that was it. There was sort of a follow-up question, which is, can we trace back the notes from the hospital for patients retrospectively?
Yes, you must do. You must do. It's normal when you're asked to revise a manuscript, where we ask you a question that you weren't expecting. We say, well, was there evidence on the CT scan 5 years ago that this lesion in the adrenal gland was there? How could you know that? You have to go back to the archive, don't you, to find that CT scan and look at it again. That's normal. So this is why we say, find your patient, choose your patient, and start digging up all the material you need for that patient at the time that the patient's with you, when you have access to the archive, when you've got all the notes there with you. Don't be surprised if during the revision stage, which sometimes can take months, you know, between submission and revising and then rewriting. Don't be surprised if you need to phone the patient at home on their mobile phone, or if you need to go back to the archive. That's all part of the writing process.
Fantastic. Okay, and how detailed should the timeline be? Sometimes it's impossible to be entirely accurate about things when looking retrospectively. What
you think is important for us to know. Don't hide anything. Never hide anything, because we're doctors talking to doctors. There isn't anything. A case report isn't an exam, and it's not a critique of how a doctor managed a patient. It's a sharing of a problem. How can you possibly discuss a problem unless you're clear about all the problems that you had? So I was looking again, bowel obstruction, my favorite surgical condition. A patient who was heavily pregnant came in with small bowel obstruction. It took well over 4 days before the diagnosis was made, and then she went immediately to surgery. The cause of bowel obstruction was something that should have been operated on straight away, but the patient didn't have ischemia, the patient didn't have peritonitis. And what the real finding of the case report is that when you come in the early stages of the condition, that diagnosis is impossible for any team, especially if you're not expecting it, because that's not your specialty. But if you are faithful to investigating symptoms as they arise, you will get there. And that was a huge part of that case report. And then they did a literature review, and what they found was that the diagnosis was clear in patients who had complications, who did present with peritonitis, who did present with complications of bowel obstruction. And that in itself was the learning point, the fact that when in their timeline, they had very little information in the first manuscript they sent. Then when we started working together and I said, no, but can you tell me when she developed distension? Can you tell me when you put in the nasogastric tube, which was on day 3? And then they got 2 liters out of the nasogastric tube. That, of course, makes your diagnosis. Can you see how on day 1, someone just has an epigastric pain, which is not typical of bowel obstruction? And then on day 3, they have 2 liters in the nasogastric tube. And as a reader, you're thinking, aha, now I see that's bowel obstruction. Then they present the operative findings, which was a congenital bad, a difficult diagnosis in any situation, pregnant or not pregnant. And they have a picture of the bowel, and you can see that the bowel is not ischemic. That's it. You see, so how much detail should you have? My teacher at school would have said, how long is a piece of string? You have the detail that's necessary to illustrate the points you want to make. Do those points change? Yes, they might change with revision. And I'm the guilty person. I'm the one that always says, could you add this? Or this isn't relevant. Could you remove this? But we will work together. It's a collaborative process. We'll work together on it. So even if it's not quite where it would be in the first draft, it will be something you'll be really happy with. And the final proof that you know that's about to be published. We do it together. You're not on your own. You're not floundering on your own without information. Work together. And you can email me directly.
Thank you very much, Seema. I think we've got lots and lots of questions here, but we're almost out of time. We might just try to fit in maybe one more. And if we haven't been able to get to your question today, I do have them all recorded here. So we will try and follow up with you after the webinar to answer any questions that we didn't get to. So last one for today. What are the charges for publication of BMJ case reports? Now, Seema, did you want me to?
Yes, I just want to say one thing, and then I'd like to hand that question to you. So I am editorial. I'm pure as the driven snow. I have nothing to do with any financial aspects of the journal. I just want to publish good content that is valuable for learning. But we have 2 models, one where an individual is paying and one where the institution pays. And I would be lying if I didn't say that I would much prefer that all authors worked with their institutions so that you have the freedom to publish as much as you want to and whatever you want to, and work with as many different multidisciplinary teams as you need to. But you're submitting under an institutional fee rather than your personal fellowship. The second thing I wanted to say is I'm totally aware that in modern medicine, you can never just have 4 people managing a patient. If you need more than 4 authors, our journal policy is 4 authors per case report. Write to me and we'll work that out. And I'll hand the rest of that question over to Elena.
Thank you, Seema. Just to let you know, I've just put a link in the chat to the page on our website, which contains further information on the fellowship costs, both for personal subscribers, and then there's also some information on those institutional fellowships as well. If you are one of our Japanese attendees this evening, we at BMJ have a partner that we work with in Japan, Yusako, and if you were interested in receiving further information on institutional fellowships and sort of, opportunities for your organization, we'd be very happy to share Yusako's contact details with you. We will include them in the follow-up communications after this webinar as well, so they can provide you with any information that you need. Okay, well, I think we have pretty much run out of time, so I just would like to say a very big thank you, firstly to Seema for that wonderful workshop that she has presented this evening, today, wherever you are in the world. I have put Seema's contact email address on the slide here, so eic.bmjcases@bmj.com. If you have any editorial or publishing queries, Seema will be happy to help. And then we also have my email address there, info.apac@bmj.com. So for any other inquiries, I'm more than happy to help you as well. But thank you all so much for attending. I hope that you found it useful and insightful. As I said at the beginning of today's webinar, we will be sharing the link to the recording as well as a copy of the presentation slides by Friday. So keep an eye out in your inbox for those. And in that email, we'll also include links to all of the author guides and the templates and so on that will help you write your case report. So with that, have a wonderful evening or day wherever you are. And thank you again, Seema. And thank you all so much for joining us.
Thank you to all of you, and I'll be sure to get to the questions that we didn't answer and email Elena all the answers.
Fantastic. Thanks,
I'm looking
Seema.
forward to your submissions. Thank you.
Thanks, everyone. Bye-bye.
Bye-bye.